So, welcome to the seventh episode of the second season of the Medicrew Masterclasses. And in today's session, we're going to talk about the biology of depression and the bipolar mood disorders. As usual, we'll start with a few questions. So, let's start with the first few sets of questions. This is your first question. Affect refers to. I'd like all of you to answer. The next question. Depression is caused by. The third question. Central serotonergic projections mainly originate from. Next question. Most effective mechanism of removal of catecholamines from synaptic cleft is. So what is the most effective mechanism by which the body removes catecholamines from synaptic cleft? Next question. In a suicidal patient with major depressive disorder, the prescription drug of choice will be. Next question. Selective serotonin reuptake inhibitors can cause. Next question. Antidepressant of choice in a patient with ischemic heart disease is. Next question. Antidepressant of choice in a patient receiving antiretrovirals and antituberculosis drugs is. Next question. Lithium acts as mood stabilizer by which mechanism? And the last question before we start discussion. Which statement is false about bipolar mood disorders? So with these questions, let us start our discussion on the biology of bipolar disorders and unipolar depression. When we use two words, mood and affect, sometimes we tend to use it in a more synonymous way. But actually, mood and affect are two different attributes. Mood is more like a longitudinal finding, whereas affect is a cross-sectional finding. The overall emotional state over months or years is the mood, whereas affect is a momentary external manifestation of a person's emotional state. So, for example, when we say that such and such person is usually a happy person, we are actually referring to the mood of the person. And then when we say that today this person is sad, that is the specific affect at this point of time. This can be compared to the analogy of weather and climate. Mood is more like the climate, whereas the day-to-day weather can change even in a particular climate type. Similarly, the affect can be different at different points of time, whereas the mood remains the same. So, mood refers to the longitudinal state of the emotional affairs, whereas affect is a cross section of a person's emotion. And it refers to the observable expression of an individual's emotional state. So, if a person is looking very blankly to me, I can say that the person has a flat affect. If a person is smiling and giggling, then I can say that the person's affect looks very happy or euphoric or elated. So these are what we mean by affect. And then if we ask this person, how has your mind been or mood been for the last 2 months? And the person says, yeah, like most of the time I was depressed. Today I am happy because today is my birthday, but otherwise rest of the days were not very good. That means the overall state of mood was depressed. Only today's affect is elated affect. So I hope this is clear to everybody. Now, when we want to define depression, how can we define depression? Depression is a pervasive lowering of the mood. So, it's a sustained lowering of the mood, and it is accompanied by various psychosocial and biological symptoms. We know that diagnosis in psychiatry is largely based on two manuals. One is the Diagnostic and Statistical Manual, DSM-5, and the other is the International Classification of Disease, ICD 11 or 10. Now, although the DSM criteria is much easier to use for diagnosis of depression, but the ICD criteria has one advantage. It can not only diagnose depression, it can also classify the severity of depression with the same criteria. That is why gradually the ICD criteria is becoming more popular among the clinicians. Overall, lifetime risk of depression has been assessed to be around 15%. That means at any given point of time, 15% of the population will experience depression sometime or the other. That is a huge prevalence. 1 month prevalence of depression is about 5%. That is, about 5% of the population will experience depression for at least 1 month in their life. The male is to female sex ratio is 1:2. Why females are more prone to depression is sometimes explained with social dynamics theories, where position of the woman in a patriarchal society become a very pivotal center of discussion as to why expression of depressive thoughts, expression of a person's mental state and venting out becomes difficult, and so the prevalence of depression also increases. The mean age of onset is in the late 20s. The risk to first degree relatives of a patient with depressive disorder of a bipolar disorder is 2%. That means if the first degree relative, like my parents, have depression, then I run a 2% risk greater than the average population to suffer from bipolar mood disorder, and a 15% higher chance than the average population to suffer for depressive disorders. The exact etiology of depression is not understood, but adoption studies support genetic theories. It's seen that the monozygotic dizygotic ratio of concordance rate is 55 is to 25. The overall risk of mood disorder in first degree relatives of a depressed person is about 20%. There are different biochemical theories that explain depression. The monoamine hypothesis is most important of them. We will explain that step by step in the next part. Depressed people also have a cognitive distortion, that is, uh, a different way of looking at life and the happenings. For example, they are more prone to overgeneralization. They are more prone to personalization of events. They also have negative views of themselves, the world, and the future. Most depressive episodes are preceded by adverse life events. Now, it's very difficult to say whether those adverse life events, like death of a near one, or separation, or divorce, or loss of a job, whether these are the causes of depression or are the triggers that unmask the depression that's already there. That is something very difficult to comment on. There are different etiologies that have been proposed to explain depression. Biologically, there are possible genes that are candidates to be identified for depression. There are different medical conditions like hypothyroidism, Cushing's syndrome, hypoadrenalism can predispose to depression. Neurochemical changes like the monoamine abnormalities in the brain and alteration of the hypothalamo-pituitary axis are also implicated in depression. Socially, the triggers of depression can be different life events like bereavement, like unemployment, and there can be psychological factors that mold or shape a person's proneness to depression, like the childhood environment, abnormal cognitions, learned helplessness, and certain personality traits like neurotic personalities. Now, coming to the ICD-10 criteria, the International Classification of Disease, version 10, classifies the criteria to diagnose depression under two groups, the core symptoms and the additional symptoms. Now, see, there are three core symptoms: low mood, loss of interest and enjoyment in day-to-day activities. This is called anhedonia, and fatigue, a constant sense of losing energy. Additional features that can diagnose depression are reduced concentration and attention, reduced self-esteem and self-confidence, ideas of guilt and worthlessness, pessimistic views of the future, ideas of acts of self-harm or suicide, disturbed sleep, and reduced appetite. Now, with the help of this criteria, how do we diagnose as well as classify the severity of depression? You can diagnose mild depression if the patient has two core symptoms and two additional symptoms. Moderate depression if the patient has two core symptoms and three additional symptoms. Severe depression if the patient has all the three core symptoms with four additional symptoms. And severe depression with psychotic symptom when the criteria of severe depression is present, and along with that the patient may have delusions, hallucinations, or stupor or catatonia. Now, there are different neurotransmitters that regulate the normal human mood. So these neurotransmitters include dopamine, serotonin, noradrenaline. It's very difficult to categorize the precise functions that they serve because they are often interrelated with each other. But broadly speaking, serotonin controls our appetite, our impulsivity. Norepinephrine controls our energy levels, our interest in activities. Dopamine controls our motivation and reward circuits. And they together control various learning, anxiety, and depression states, as well as the overall mood and cognition. The monoamine hypothesis suggests that a decrease in one or more of the monoamines in the brain are responsible for causing depressive symptoms. But again, it is very difficult to say whether the chemicals decrease before the onset of the symptom or it is because of the depression that result in the decrease in these chemicals in the brain. If you look at the major serotonergic tracts in the brain, most of the serotonin pathways originate from a group of nerve bodies known as the raphe nuclei. So the raphe nuclei are the starting points of the major cortical serotonergic tracts. And reduced serotonin from the tracts of raphe nucleus have been implicated to depression. Dopamine has some major pathways in the brain, and we have already discussed about this in our previous episode on Parkinsonism. The mesolimbic and mesocortical tract is responsible for controlling the cognition, intellect, and emotion. So decreased dopamine in the mesolimbic pathway has been implicated to cause depression. Noradrenaline is mainly secreted from the tracts originating in locus coeruleus. And reduced noradrenaline is also associated with features of depression. So, what is the basic principle of monoaminergic transmission in the cortical neurons? If we use a simple schematic diagram to understand the biology of the neurotransmitters and how it causes depression, it will be easier for us to understand how depression can be treated. Say, for example, uh, this is an axon terminal. And inside the axon terminal, we have synaptic vesicles. Now, the monoamines like serotonin, noradrenaline, or dopamine, I am writing serotonin as an example, which is also called 5-hydroxytryptamine. This 5-hydroxytryptamine, after being synthesized, is stored in the synaptic vesicles. The storage in the synaptic vesicle protects it from the action of monoamine oxidase, which is a mitochondrial enzyme that digests the monoamines. The monoamines will remain stored in the synaptic vesicles until there is a nerve impulse that arrives. When a nerve impulse depolarizes the axon, this causes opening of voltage-gated calcium channels, causing the influx of calcium ion. And this calcium causes release of the neurotransmitter. So the neurotransmitter is ultimately released into the synaptic cleft. Now, the neurotransmitter, after being released, can have multiple fates. Neurotransmitters like serotonin, noradrenaline, or dopamine can bind to their receptors and cause biological effects. So this will bring out a response. It can be metabolized by certain enzymes. Enzymes like monoamine oxidase inhibitors or similar such enzymes can help in metabolism of the monoamines. The serotonin can be partly taken up in the same neuron and recycled. This uptake happens with the help of a very special receptor or a transporter. This transporter for serotonin, for example, is called the ACRT or the serotonin transporter. And this kind of a neuronal uptake is known as uptake 1. Uptake 1 is responsible for removal of about 75% of the neurotransmitters and is the main method of removal of neurotransmitter from the synaptic cleft. Metabolism usually accounts for slightly less than 25% of the total neurotransmitter removal. And the remaining very small percentage will either bind the receptors or it can be taken up by non-neural tissues like the glial cells or blood vessels. And this uptake is sometimes known as uptake 2, which is a very minor part of the uptake. A small amount of the released serotonin can also act on presynaptic receptors. And by acting on the presynaptic receptor, it can regulate its own release. And so these receptors are called autoregulatory or inhibitory receptors. And these autoregulatory receptors cause inhibition of the release of the neurotransmitter. So this is a summary of what happens in a monoaminergic transmitter, and there are different drugs that can affect the whole process. If we block the uptake 1 pathway, then about 75% of the neurotransmitter will be available more and more at the synaptic cleft. So the classical reuptake inhibitors are uptake 1 inhibitors. There are different molecules that can prevent the reuptake of monoamines. For example, tricyclic antidepressants, cocaine, wabane can block the reuptake of almost all monoamines, including noradrenaline. The uptake of serotonin can be blocked by SSRI or selective serotonin reuptake inhibitors. Uptake of both serotonin and noradrenaline can be blocked by SNRI or serotonin noradrenaline reuptake inhibitors. And then we also have atypical drugs like the NDRI, which are noradrenaline dopamine reuptake inhibitors. These drugs, when given in the proper therapeutic dose, increase the synaptic concentration of the neurotransmitter, and so the action of the neurotransmitter increases. And this forms the basis of most of the antidepressant therapies. Additionally, another important target is to inhibit the enzyme monoamine oxidase. Drugs like the MAO inhibitors can cause reduced metabolism and therefore further increase the bioavailability of the monoamine neurotransmitter, thereby increasing its level in the brain. So I hope this is clear up to this. So you see, the serotonin transporter or norepinephrine transporters, they are all blocked by drugs like the tricyclics, the serotonin noradrenaline reuptake inhibitors, selective serotonin reuptake inhibitors. And the enzyme monoamine oxidase can be blocked by monoamine oxidase inhibitors. One very important feature of antidepressant drugs is that the brain level of monoamine increases soon after taking the drug. But the effect of the drug does not start immediately. That is, suppose if a person is depressed and the serotonin level in the brain is low, if you give a dose of a selective serotonin reuptake inhibitor to that person, within 12 hours, the brain levels of serotonin will become normalized. But the mood will not be elevated immediately. This is known as a therapeutic delay. And this delay is caused by a very complex mechanism. What we now know is that these monoamine neurotransmitters stimulate certain response elements in the gene known as the CREB. It is a cyclic AMP response element binding protein. And by stimulating the CREB element in the nucleus, it increases the synthesis and secretion of neurotrophic factors like the brain-derived neurotrophic factor. These nerve growth factors cause proper maturation of the synapses, sprouting of the dendrons, and therefore better connectivity in the brain. And this whole response takes about 3 to 4 weeks of time. That is why immediately after the monoamine level is increased in the brain, the antidepressant action is not seen. It takes time for stimulation of the CREB, synthesis of brain-derived natriuretic factor, and therefore reconstruction of the degenerated synapses. So as I was saying, based on the reuptake inhibition mechanism, we can classify antidepressant drugs. So most popularly used drugs at one point of time were the tricyclic antidepressants. The typical drug that is under this category is amitriptyline or nortriptyline. They have a relatively rapid onset of action. They act within 3 weeks. The drugs have a lot of side effects because they have antihistaminic, anticholinergic, different kinds of actions that are responsible for sleepiness, that are responsible for dry mouth or weight gain. Remember that the tricyclic antidepressants not only increase serotonin but also noradrenaline in the body. As a result, they are potent adrenergic drugs. Being adrenergic drugs, they can precipitate hypertensive crisis or angina in patients with cardiovascular disease. So we should be very cautious while using tricyclic antidepressants in patients with heart disease. The selective serotonin reuptake inhibitors only elevate serotonin levels in the brain. And as such, these are one of the most safe category of drugs. The side effects are minimum and they can be simply explained by increased serotonin in the body. The prototype of the SSRI drugs is fluoxetine, which is also the first SSRI to be clinically approved. And these drugs, apart from causing a little bit of yawning, not exactly sleepiness, but specifically yawning, low appetite, because serotonin is a central suppressor of appetite, and loss of libido or sexual urge. Other than this, they usually do not cause much problem. In some individual, increase in the serotonin may result in mild symptoms of gastritis or loose motion. This can be prevented by using a proton pump inhibitor along with the drug if necessary. The drugs usually cause disturbance of sleep, and also it can increase anxiety in the first few days of therapy. So it's suggested that for the first 1 week or 2 weeks, we add a mild benzodiazepine with this, like clonazepam. Serotonin noradrenaline reuptake inhibitors are basically a tricyclic antidepressant with less side effect. So it's a more refined tricyclic antidepressant. A typical example is venlafaxine. Monoamine oxidase inhibitors can elevate noradrenaline levels very severely. Therefore, they should be very cautiously used in hypertensive patients, and they should be very carefully combined with other kinds of drugs. We should also be wary of cheese reaction happening with this category of drugs. So the person should refrain from taking wine and cured cheese. The other antidepressants include tetracyclic antidepressants like mianserin, noradrenaline reuptake inhibitor like reboxetine, noradrenergic and specific serotonergic antidepressant like mirtazapine, and noradrenergic dopaminergic reuptake inhibitor bupropion. Incidentally, mirtazapine is also recommended in depression with insomnia, and bupropion is also recommended when a person has loss of libido or has a smoking addiction that can be treated with bupropion. A person with cardiovascular disease is best treated with the help of the SSRI. Usually, SSRIs are very safe in cardiovascular disease. The safest, however, seems to be sertraline. So, in a patient with a coexisting cardiovascular disease, sertraline is the antidepressant of choice. Similarly, escitalopram seems to have very little drug interaction. As a result, if a person is taking too many drugs for other medical indications, then to avoid drug-drug interaction, it is usually safe to use escitalopram compared to other drugs. So I hope up to this is clear to everyone. So what will be the expected finding if we clinically examine a patient with depression? The overall appearance may show signs of neglect, like weight loss or unkempt appearance. Behaviorally, the person may have poor eye contact, downcast eyes. So the overall the person might be a lot withdrawn from the surrounding. The person may also be tearful. Speech may be slow, non-spontaneous with reduced volume. The mood may be low and may have suicidal ideation. Thought may be predominantly pessimistic with ideas of guilt, worthlessness, and nihilistic delusions. Delusions that the whole world is going to end and nothing really matters. Perceptions are usually intact. Only in some rare instances where there is depression with psychotic symptom, hallucinations may be present. Cognition shows poor attention and concentration. However, the insight is usually good. That is why classically depression is a neurosis and not a psychosis, except for exceptions. There is no specific biochemical investigation for depression, but you would always like to rule out the underlying electrolyte disorders or any precipitating cause. So it's good to do a thyroid function test, a full blood count, a liver function test, urine analysis, serum calcium and glucose. Because diabetes mellitus or hypothyroidism may be additional comorbidities present with depression. Because liver function test is a good baseline evaluation before you start a drug therapy. And also because electrolyte anomalies may be present or aggravated when there is psychogenic polydipsia. So that is why these baseline investigations done before the administration of therapy is usually helpful. Management includes assessment of risk. So assess the risk of suicide, risk to others, and risk of self-neglect. And thereby you minimize the adverse life events. If it is mild depression, primary care at home may be sufficient. But if the patient has severe depression or is suicidal or psychotic, then psychiatric referral or hospitalization is needed. Drug treatment is done with tricyclic antidepressants or SSRIs as the starting first line drug. Usually, SSRIs are becoming more popular than tricyclics because of their safety profile. When a person is severely suicidal, try to start with SSRI because tricyclics can be overdosed. Try to avoid benzodiazepine because benzodiazepines can be overdosed. So, in a patient who is overtly suicidal, the safer drug to start with are the SSRI. In general, there is a very small difference in the efficacy and tolerability between different SSRIs. So the choice is essentially that of the physician, and it is the side effect of the drug that guides the use of the specific SSRI. Also remember that as the patient improves, the suicidal urge can increase. So the first few weeks of therapy are very important for monitoring suicidal ideation. Antidepressants should be continued for at least 6 months after symptoms have resolved. They may be taken prophylactically following multiple episodes. Sometimes we will need antipsychotics like olanzapine along with a drug like fluoxetine in relation to the depressive episode. Electroconvulsive therapy can be used for treatment of drug-resistant depression. And this can be supported with psychotherapies like supportive psychotherapy, cognitive behavior therapy, and interpersonal therapy. So when do you refer a patient with a prominent psychiatric symptom of depression? When the patient has not responded to treatment, or there is a substantial risk of harm to self or others, or when you need a second opinion on the diagnosis or treatment, or when you are using a combination of drug which may be dangerous or which are rarely used. It's good to take an expert opinion. When a specialized psychological therapy is needed, then also we should refer to a specialist. And if the patient is severely unwell and hospital admission may be necessary or electroconvulsive therapy may be necessary, a referral to a specialist will be warranted. So up to this, I think this is clear to everyone. And this, I think, are the nutshells that we need to know about depression in general. Bipolar disorders, it is a relapsing and remitting disorder. It is a disorder that is characterized by the presence of periods of elated mood or very happy phases, which are called mania or hypomania, and periods of depressed mood. Although the presence of elated mood alone is sufficient for the diagnosis. It is an observation that mania never happens in an isolated way. If a person suffers from mania, it can be very comfortably concluded that the person has a bipolar disorder. So, to explain what the different changes in mood can be, the average normal mood is known as euthymic state. A manic episode is a sudden flaring up of the mood, often to the extent of developing grandiose delusions. The person becomes talkative, starts taking unnecessary risk, starts spending a lot of money. Then this can be alternated with depressive episodes. A mild manic episode where there is a outburst of creativity is sometimes known as hypomanic episode. Based on the combination of these episodes, we sometimes classify bipolar disorders. So how do you recognize a hypomanic episode? Hypomanic episode is a happy state with high creativity. So there is a persistent mild elevation of mood for more than 3 days. So at least 4 days is necessary for the diagnosis. There is increased activity and energy, decreased sleep. The person becomes talkative, also behaves in an overfamiliar way, and there is increased sexual urge. Mania is something more florid than this. There is elated mood or irritability for more than 7 days duration, with complete disruption of work and social life. There is increased energy and pressure of speech. The person is constantly speaking in high volume. You cannot stop the person from speaking. There is a feeling of high creativity and mental efficiency, and this can lead to grandiose idea. People can even start believing that they are superheroes or they have supernormal powers. The expenditure can be very excessive and can even lead to dates. There is a gross sexual disinhibition, partly because probably there is a rise in dopamine level as well in the brain, along with serotonin. The reduced sleep may lead to physical exhaustion. When mania is present with psychotic symptom, then we have all the above features. Along with this, we often have delusions of grandiosity and auditory hallucination may be sometime present. So how do we differentiate hypomania from mania? As I told you, hypomania, to make a diagnosis of that, the features should be present for 4 days, that is more than 3 days. Features of mania should be present for at least 7 days, or there should be a history of hospital admission. In hypomania, the core features are mild or moderate. In mania, they are highly exaggerated. The dysfunction in hypomania is also mild to moderate, which is substantial in case of mania. In hypomania, the insight is preserved and therefore there is no psychotic feature. In mania, there is almost no insight and so psychotic features may be present. Mania is one example where you cannot draw the line between neurosis and psychosis because it presents with features of both. So bipolar disorders are often classified into different types. One way to classify bipolar mood disorder is to divide it into type 1 and type 2. When a person has alternate episodes of depression, mania, depression, and so on, then that kind of a cycling is known as type 1 bipolar disorder. And when a person has a background depression with occasional islands of hypomania. So the background is constructed of overall depression, but along with these depressive episodes, occasionally the patient has hypomanic episodes. Then such a cycle is known as type 2 bipolar disorder. So in type 1 disorder, there are frankly alternating manic and depressive episodes. In type 2, the person is mostly depressed with occasional islands of hypomania in between. There is one important category of bipolar disorder which is called cyclothymia. It's a mild chronic bipolar variation of mood. So the person is almost always bipolar. And so much is the consistence of the condition that sometimes it can be viewed as a personality trait. Psychiatric help is rarely sought since the mild mood elevations are pleasant and they are usually associated with a sense of productivity and creativity. That is why cyclothymia is also often not diagnosed properly. But it is important to diagnose this not for the treatment purpose, but because if a patient is cyclothymic, then the person also has the risk of developing depression at some point of time. Similarly, if a person is cyclothymic, there is a chance that giving an antidepressant drug can trigger manic episodes or drug induced mania in that person. That is why the history of cyclothymia is very important in psychiatry. The exact etiology of bipolar disorder is not very clear. Genetic factors have a strong contribution, unlike depression, where the contribution was not probably so clear. Heritability is estimated at 85%. The concordance rate among monozygotics is about 80%. And the risk of bipolar illness in first degree relatives of those with bipolar is about 8%. So, although specific genes could not be isolated with confidence, but we can definitely say there is a prominent genetic link. Clinically, in the manic phase, the person will appear totally inappropriately dressed with flamboyant bright colors. There can also be neglect of personal hygiene. The behavior will be overfamiliar, often flirtatious. There will be increased psychomotor activity. The patient is easily distractible, restless, and running around. The patient speaks in a loud voice with pressure of speech, uninterruptible, with flight of ideas, jumping from one statement to another statement, and they are all intersected with puns and rhymes. The mood of the person is elated, and sometimes we call this an infectious elation. So when a manic patient comes in front of you, sometimes the whole department starts to laugh, looking at the mannerisms of the person. The thought may have elements of grandiosity and occasionally persecutory delusions. And there may be perceptual anomalies like auditory hallucination, often congruent to the mood. Maybe the person is hearing that some people are saying that he or she has become a superpower or a god man. Bipolar disorders are treated with mood stabilizing drugs. It is presumed that rapid cycling of IP3-DAG in the neuron causes bipolarity. So the drugs that we use aim at stopping this rapid cycling of inositol triphosphate. The drugs that we commonly use are lithium, which is usually given as a citrate or carbonate salt. Second generation antipsychotics, most widely used one is olanzapine or quetiapine. Anti-epileptic drugs like valproate or carbamazepine. Lamotrigine is also a good choice, particularly for cyclothymic disorders. An acute manic episode requires the use of a mood stabilizer along with a sedative to calm down the patient. Lithium takes a long time to act. So lithium, although can be used, is not always preferred as the drug in acute phase. It's better for prophylaxis. Acute phase is better treated with drugs like olanzapine. With or without a benzodiazepine like diazepam or clonazepam. In general, most second generation antipsychotics and almost all antiepileptics have mood stabilizing action. The action of lithium has been a matter of controversy for many years. Now we understand that in a bipolar person's neuron, probably there is a rapid cycling of the inositol triphosphate. The recycling of inositol is prevented at multiple levels by lithium. Even the import of inositol through a sodium exchanger is prevented by lithium. This is also partly because lithium and sodium are both group 1A metals. So one can block the effect of the other because of similarities in the electronic configuration. So these are the principal sites of action of lithium. It acts by blocking sodium channels or exchangers as well as by blocking the recycling of inositol, which is probably the most important mechanism. Additionally, it can also cause inhibition of enzymes like the glycogen synthase kinase or GSK beta. This is a very important enzyme that regulates various neuronal function. It doesn't stimulate it, it inhibits this enzyme. And as a result, the neuronal metabolism decreases. So these are the proposed mechanisms of action of lithium. Bipolar disorders are important because many complications can happen in bipolar patients. It's seen that 10% of people who have bipolar affective disorder commit suicide. Alcohol and substance misuse can complicate the overall picture. Non-compliance with prophylaxis is an important issue. Abrupt withdrawal of a mood stabilizer carries a high risk of relapse of mania or depression. Usually 50% of the patients relapse within 5 months if lithium is stopped. A minority of the patients develop rapid cycling of 4 or more episodes per year. That is why it's so important to develop increased awareness and empathy towards psychiatric conditions like depression and bipolar disorders. It's important to recognize the symptoms and to seek help whenever necessary. So, this was today's presentation. Let us try to answer the questions that we started with. So, what will be the answer to this? Affect refers to. Very good. Affect refers to the external manifestation of a momentary state of mind. It's a cross section of the emotional state. Depression is caused by. Wonderful. Depression is caused by all of the above. Central serotonergic projections mainly originate from. Correct. The answer is raphe Locus ceruleus is the area from where the noradrenergic projections occur. Ventral tegmental area gives rise to the dopaminergic projections. Striatum has different kind of projection, including dopaminergic as well as serotonergic, but they are not major ones. They are minor ones. Most effective mechanism of removal of catecholamine from synaptic cleft. Very good. The answer is uptake 1. Uptake 1 is responsible for removing 75% of the neurotransmitters. In a suicidal patient with major depressive disorder, which prescription drug will you write? Very good. The answer will be B, selective serotonin reuptake inhibitor. They have little chance of being overdosed and also they are relatively safe drugs. The other options all have the chance of being overdosed and can be used for suicide. SSRI can cause. Very good. It can cause all of the above. It's also important to clarify that SSRI increases yawning, but it actually does not increase sleep. Serotonin is a central sleep suppressor, so it actually reduces sleep. What it causes is it causes a sense of fatigue and yawning, probably by some direct action at the centers of the brain responsible for yawning function. Antidepressant of choice in a patient with ischemic heart disease. Wonderful. The answer is sertraline, the drug that is safest to be used in presence of a cardiovascular disease. Antidepressant of choice in a patient receiving multiple drugs or polypharmacy. Yes, the answer is escitalopram. It is a drug having minimum drug-drug interaction. Lithium acts as mood stabilizer by which mechanism? Very good. The answer is A, by preventing the recycling of inositol. And the last question, false about bipolar mood disorders is. Which statement is false? Very good. The answer will be D. The statement was a single episode of mania does not imply bipolar mood disorder. The fact is it does. Even a single episode of mania is sufficient to diagnose bipolar mood disorder.